Hello and welcome to Unclenched. I'm here with my girl Priya, and we've got a very interesting doctor on today. His name is Charlie Simkovich from the Pittsburgh area, and we will get into exactly what he does and how he does it. And it's really, really, really fascinating. And Priya, though, before we get started, what's going on? How you doing?
Same old, like just hanging in there, but I have hired an associate. So I'm very excited about that. He's going to be
Yeah.
starting Mondays and Tuesdays. I guess he officially started this week. And so I'm so excited about that. And once he's on, I'm going to for real, I'm going to start taking Mondays off. I'm not quite there yet.
Yeah.
But once I have a weekday off, I think that's just going to help my life and my schedule a lot. So I'm excited about that. What's new with you?
Yeah. Well, nothing much. Got the one daughter settled in Denver, and she's out there getting ready to start her dental residency. So real excited about that. And so everything went nice and smoothly. Real good, real good.
Congratulations.
Yeah, I'm just so excited. So I'm excited
Oh.
for her, but unfortunately, when we were out there, we were in a restaurant and she slipped and did like a split. Like one leg went forward and landed on her back knee, and she cracked her kneecap.
Ah,
So she's in like a full leg brace. My baby's out there by herself and trying to manage. At least it's on her left leg, but
sorry.
she can't bend it right now. They just increased it to 10%. So, but she starts her residency in July 1. So hopefully she'll, recover a little bit more. Like, I don't know.
Sure.
And they wouldn't let me bring her home because they said she can get a blood clot on the plane. So
Yeah, yeah.
she's there. I'm here, and I call her all the time. Mom, what do you want? I'm fine. Okay. Yeah.
Mm,
But
yeah.
yeah. So you have any patients or anything that stand out to you this last couple months or
Um,
month?
who has stood out to me? Yeah, yeah. Again, I keep talking about DTR, and it's just been amazing. We have a patient who he was just in so much pain, and he has two little kids. They're like 2 and 4, and he just wasn't even able to play with them at night or spend any time with them. All he could focus on was the pain. And so after one DTR session, I mean, he felt like 40 to 50% better.
Mm-hmm.
And then he had a little bit of rebound. Some of the pain came back, but not to the same level that it was
Right.
previously. So he just did his third DTR session, and I texted him this morning, and I'll read you exactly what he said. It's just so great doing this work and providing relief for these patients. It's so gratifying. He said, where is he? Where is this guy? Okay, he said, I said, how are you feeling? He said, better, some soreness as my jaw is figuring out the new adjustment, but the symptoms I was feeling are definitely improving. And I said, oh, good. And he said, I haven't had any nerve pain since I came in. Nerve pain was like his number one thing in his
Yeah.
face. So
Yeah.
he's feeling a lot better. What about you? Is there a patient that sticks
So,
out to you?
so funny you should mention that, because I had a patient in this week too, and it was a DTR candidate, but she came in. In fact, we just did a little testimonial, and I'll be putting it on my YouTube channel. But she couldn't touch her. She'd hold her lip out like this because when
Oh,
her lip touched her front teeth, she'd go into a lot of pain. And she lost over 20 pounds. She couldn't eat. She was depressed. And I cried when we talked yesterday. I cried, and she was saying that she was ready to end her life
oh,
because of the pain. And she was saying that, she's like, okay, I just have to get until my daughter graduates. I want to
yeah.
see her graduate from high school and get her off to college, and then she could end things. I mean,
Mhm.
this is what, and the way she's like, you've changed my life. The pain is so minimal right now, but we've been doing some laser therapy with her too to decrease the inflammation. But the DTR again saved her life. I mean, it really
Wow.
did. So it's really, 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 really amazing.
Really
But
powerful.
yeah. But one of the other doctors that I work with is Charlie Simkovich. So let's bring Charlie on now.
There he is.
Okay. This, Priya, is Dr. Charlie Simkovich. He went to school as a chiropractor, and got a degree and what have you, but is totally doing things so much differently and not so much chiropractic care. But he is my go-to when I have patients that come in with any kind of concussion symptom or a history of concussions, because Charlie will tell you they build on it, and he goes in and adjusts some bones of the head and the sphenoid bone. But Charlie, let's talk about that. So tell me exactly how you came to this kind of focus in your practice and how it all evolved.
Yeah, so I my formal degree is in chiropractic, and I was practicing for about a year, and I like the field. I just didn't know if I could do that the rest of my life. It wasn't challenging me enough. So I actually had enrolled. I got accepted into a med school in California, and was going to do that. But then a friend of mine was involved in research on cranial bone movement and the effect it has on how your brain functions in Brooklyn. And he said, you need to come see what we're doing. It's pretty fascinating. And their first focus was for learning disabilities and dyslexia. So I went out to Brooklyn, and it was a mix between neurologists and chiropractors. And they were in the process of identifying what these cranial faults were and really how they affected the brain. And the patient that I saw that week witnessed going through the treatment is what really turned me around. It was a Hasidic Jewish boy from Belgium who was 22 and never had spoken more than a 2-word sentence. And the third day, and mind you, the treatment was rudimentary compared to what it is now. But the third day, he had never been to America. In perfect English, he said, get me out of this room right now. I want to go to the hotel. And so his mother started crying. I mean, it was really emotional. And I thought, okay, these people are onto something. So after about 6 months, I went back to the team. There were 6 of us. And I just said, listen, we're really actually figuring out how to deal with concussions and traumatic brain injuries, because these cranial faults are causing everything we're seeing for learning problems. And so they kind of carved that out, and that was the direction I went. And we still work together. It took 7 years because there was really nothing out there about concussions, and there was no precedent. The best we had was we based it all on Dr. Syriac's, his theory, which is he's the father of orthopedic medicine. He basically said with any traumatic injury, the treatment must reach the source of the injury. And so we started looking at the source, and then we started looking at Dr. Donald Sutherland, who was an osteopath, who was the pioneer in looking at cranial type of injuries and adjusting. And we started looking at Dr. Ferrari, who was actually on the team out there, who was taking Dr. Sutherland's information and developing it, and then physical therapists and neurologists. So it was a real fusion of all the different specialties. And there was no precedent. So it was all trial and error. There was really nothing. I mean, when we started this, prevailing knowledge in the medical field was cranial bones don't move. Right. And I was thinking, well, if cranial bones don't move, how can orthodontists put expanders in the upper jaw and widen the jaw? Of course they move. So then a study came out in Michigan State University's Department of Physiology in the med school, where they actually quantified movement of the sagittal, the parietal suture in squirrels. And that's a very hard suture to move. So they quantified movement of the least movable suture in the skull. So and then we were off to the races. So that the team, we'd all get together and would throw the theories out, go back to our offices, and whatever worked, we kept. Whatever didn't work, we discarded. And eventually we came up with a system. And then I kind of took what I do, and Alex knows the treatment, the delivery is pretty intense. I do a lot of work with NHL alumni, and their neurosurgeon calls this bloodless surgery. So we look to the sphenoid bone, and the sphenoid bone is like Grand Central Station in the skull. all of the other cranial bones articulate with it. Your jaw muscles, like the internal and external pterygoid muscles, attach to it. So jaw motion can affect the sphenoid. Your eye muscles attach to it. So it affects tracking ability and kids' ability to read fluently. You have 3 cranial nerves that pass through the sphenoid, 3, 4, and 6, the oculomotor, trochlear, and abducens. So if this gets torqued, they can be stretched, which reduces their function. Your optic nerve passes through it. So vision is heavily impacted. And it houses the pituitary gland in the sella turcica, which is the master gland. And a lot of our findings, we use Dr. Madonna as our radiologist here in Pittsburgh, and we see empty sella a lot. And now we're finding hypothyroidism, irritable bowel syndrome. The hypothyroid attaches to the pituitary, which tells it what hormones to secrete, which is the reason why erectile dysfunction is so prevalent in retired NFL football players. Retired NFL football players are 5 times more likely to have ED compared to the general population. Then we add to that behind that's the pineal gland, which regulates serotonin secretion, which is what's amiss in PTSD, and it secretes melatonin, which is why sleep can be affected. So we've found a whole syndrome of health problems that can go away with stabilizing cranial bone movement. A lot of people say, well, are you putting my cranial bones back into place? No, the skull is dynamic. It's moving. It's not static. So we're restoring movement. So all of physiology of the CSF flow and blood flow and eye movement and jaws stabilize. Then you add to it that the glymphatic system, or the waste removal system of the brain, slows down when you've been hit in the head. And all this research was done by a medical doctor, Dr. Nettergaard. She's in Rochester, New York. She identified the glymphatic system. The CSF flows around the brain, grabs the waste that the neurons dump, which is a lot, and it pumps it into subarachnoid space, sends us through aquapore and 4 pores, where it goes back into the brain, and the brain then cleans the waste products, things you'd expect like carbon dioxide. It also cleans out tau proteins, which if that builds up causes CTE, or chronic traumatic encephalopathy, and beta amyloid proteins, which is what causes dementia. So
Wow.
Dr. Nettergaard did further studies where she determined that concussions shut off the glymphatic system. So that explains why a lot of my patients, when we start to treat, they sleep. They go into a deep sleep, which we know we kick them.
I've had patients tell me after you've adjusted them that's like the best sleep they've had, or they sleep in your office or what have you. But what about whiplash? Whiplash, is that the same as concussion? Because a lot of my patients will say they were in a wreck and they had whiplash, but they didn't have a concussion.
Yeah, well, let's look at what alters brain function and what I call concussion-like symptoms or alteration in brain function. First, you have blunt force, which is a concussion. Then you have a coup contra coup injury, which is whiplash. So your head is whipped real hard. Your brain actually bounces off the inside of the skull, then rebounds and hits the other side. That's sometimes more traumatic than blunt force. So you have that. Then there's a hematologist that did a study. He took blood from a population of patients that he defined as healthy, whatever his definition was. He got a baseline on what your blood looks like. Then he took blood from patients who had physical trauma, concussion, broken bone, stab wound, and they had whatever certain abnormalities in their blood. Then he took blood from a population of patients that had emotional trauma, like a death in the family or a divorce, and their blood looked just like the people who had the physical trauma.
Wow.
Then to take it one step further, I have a cousin that's an anesthesiologist. In fact, she went to WVU, and she was talking about this. Yeah. And then she's retired already, lucky thing. But anyway, she talked about chemical trauma. So people have all kind of chemical changes in their body, like menopause, hormonal problems, allergies. But she specifically talked about general anesthesia and anesthesias. She said, think about it, Charlie. Somebody has open heart surgery, your chest is cracked open and you don't feel it. That's very traumatic to the brain. So we have those 4 scenarios where we do a lot of work. I get a lot of people post-surgery or chemo then it's affect their brain. So that we call that chemical trauma. And a lot of times you can stabilize that by helping the brain wash with the lymphatic system and blood flow, stabilizing blood flow.
So how do people, or how do doctors, because a lot of people don't even know you exist. Like, are there a lot of trained professionals like you with adjusting the bones of the head and the sphenoid, and how does somebody go about getting that kind of training?
That's my question too is, who like you is near me?
That's a problem. That's a problem we're trying to address. I developed this to the point that it is now. And the reason it got to this point is I had a lot of people from out of state saying, listen, I can't, because before that, our patients, it might take 2-3 months, and people don't have that time. So we had a professional boxer. It was a patient, Roy Jones Jr., and he's in Florida. And he said, I don't have time to keep coming back. Isn't there some way where you can compress this? And so that's when I developed this intensive treatment, and it turns out it's much more efficient. So I developed this. So there's really nobody doing this. When we did our initial work in New York, we trained 2,000 doctors from here to Australia. And then we had a proficiency practicum that they had to pass in order for us to refer them, because our reputations were on the line.
Sure.
Only so many doctors passed that. There's a lot to know. Not only do you have to know who you can help, you have to know who you can't help.
How many passed? Sorry, I didn't hear you.
70. And
out of 2,000?
Yeah. And the problem, and that was our referral base, and they were all over the place. And the problem was, it wasn't what it is now. It wasn't developed to this. And unfortunately, a lot of doctors think they know better, and they go out and they start bastardizing the technique, and
Right.
It wasn't done properly, and people weren't getting results. Plus, it hadn't been fleshed out to the point of what it is now. None of them, they know nothing about the intensive treatment protocol. And a lot of them, this was years ago, late 80s, early 90s. So people are dead. So our challenge is we want to start training people, but how do we go about that? My wife, and you know her, Alex, she's got her MBA from Duquesne. She's a business person. She used to be pretty high up with Westinghouse Air Brake. They manufacture locomotives. So she partnered with a guy named Dan Akers in Texas. Dan was an international businessman. His father was Fred Akers. He coached the University of Texas football team. He coached Earl Campbell, if you remember him.
Yeah.
So Dan was a businessman. Well, Dan's son, Hunter, had so many concussions, he was on suicide watch. Couldn't read, anything. So they flew here to Texas. And long story short, Hunter's doing great. So Dan started working with my wife to say, listen, his idea was to start a residency program, start training. He wanted to do it through the University of Texas. It never got off the ground because he wanted to train doctors and put them in clinics around the country. I'm sorry. And unfortunately, about 7 or 8 years ago, Dan died from renal cancer at 54. So now we were left, and that's a big undertaking, trying to figure out how to train these doctors, because I'm in the clinic. When do I have to shut down? To train? So right. My wife and I are recent. I think what we've decided is we already have the blueprint of how things work here. People come in here. So we're going to add doctors here and have them work under me. So we make sure everything is done the way it should. Then we can start spreading them around the country. Because people, last week we had somebody from Australia and Peru here. So they come in already. So we have the blueprint of how to do it. Yeah. We had a lot of people we've had people from Washington State, British Columbia. Yeah. So.
Well, some of my patients, because one of the things that I love about you is that I've sent you patients, and sometimes you're like, yeah, you're not a candidate for my treatment. Like, it's not like everybody that goes there is able to, or you don't think they're going to benefit from what you can. And I appreciate that, and they appreciate that. But what is it that you are looking at when you say, you're not for me?
Well, the whole picture, usually there's some kind of studies, either CT or MRI. We need to rule out any kind of pathology. You look at the history, you look at the age, the type of injury that they had. There's certain places of the skull are more susceptible to bigger injuries, like the temporal bones. They slide up and down on the parietals. They look like a fan. There's not a lot stopping that. So injuries to this area are usually more severe. Your jaw, you ever see, your jaw when it gets moving and those pterygoid muscles, they can really tug at the sphenoid. You've seen a boxing match where somebody's hitting the jaw real hard and they drop like they chop. So there's certain areas, we're more vulnerable and more susceptible. Age is a factor. And then the exam tells me I examine the pterygoid processes of the sphenoid, the greater wings, the parietal bones. A lot of times I see edema in the parietal suture. So then you piece it all together. And then the history, like I had a lady, she said one thing that was a real red flag. And so I walked her back down a path of questions. When she said that, I actually put her in a cab and sent her to AGH. She was in brain surgery. In an hour, she had 4 aneurysms they were tying off. So she said that one thing that you knew was a problem. Then I had another guy, by what he said, I knew he had he probably had likelihood of a tumor by the way he was describing the pain. I sent him to Frank. He had astrocytoma and he had brain surgery. So the good thing is with this, you can find out what you can't help and then usually make the proper referral. Like I've examined people and send them to you and don't touch them.
Right.
So that's more appropriate. I think I sent 2 last week. So it, not only knowing who you can help, but who you can't help, and then having the appropriate physician to send them to so they can get help. And it's a good marriage between what you do and I do and Dr. Ross. And
Dr. Roth is an AO chiropractor that we utilize for any So we got our little trilogy going on. I should say.
Well, Dr. Alex, do a lot of your patients see both then, the AO and?
Number. Some need all 3 of us. I would say 20% of my patients need Dr. George or Dr. Roth or both. It's a real good marriage because it's hard to separate all this.
Mm-hmm.
The jaw is very influential in brain health and in the skull.
Yeah.
So, usually those are the tougher cases. We've had some tough cases.
We
always have that one,
Do you have a referral source in Washington or Oregon?
You mean for ICCMO, for JAWS?
No, for what you do.
Nobody does what I do except me.
Nobody. Okay.
Yeah.
So
that's why
that's our next order of business is training doctors and getting them out there.
Sure. Okay, got it.
I don't know. My wife, we know we're going to have some here. Then we're thinking about putting them in different orthopedic groups around the country. That's
right. Well, I guess I was wondering, like, if those 70 people that passed the test, if any of them are in my area, but never mind.
No, most of them are retired or dead. I was very young at that time. I mean, that's the blunt answer. I was the young person. Even the people that were close to my age, like there was a practitioner from Missouri named Diana Franklin, and I hadn't heard from her in 2 years. I Googled her. Here she passed away, and she's not that old. So, unfortunately, the attrition rate has been depressing.
Yeah.
Because a lot of them aren't around anymore.
Sure. So, with like Priya, we had a patient we were talking about before you came on, and she has been to me, to Dr. Simkovich and Kathy Roth. And the thing is, when I see my patients, like people will say my jaw pain is good, but my neck is still bothering me or my shoulders. And like, I don't just stop at the jaw. I'm like, well, okay, let's figure it out. So then I try to hook them up with, either PT or one Charlie or Kathy, because, I just feel like I got to complete the circle. I mean, I know in dental school, we're just trained right here, but how can you just stay right here when there's a body attached to it?
Right.
a lot of people with like, brain fog and if we get rid of a lot of their stuff, and I'd say a majority of the patients I'm it and it's good, but then I might have 30% of my patients that when we dig or they have a hip off or,
Mhm.
I'm always referring to someone.
Everyone has a hip off, girl. Everyone. Seems like.
So
Yeah.
it's like I want to help them as much as I can. So that's why I keep trying to find out who else I can put in my back pocket. And Charlie better get his butt going and get someone to trained because come on, Charlie. Come on.
We actually have a doctor in Australia that wants to work.
Australia's not here.
Well, no, he's going to move here. We got one in northern Michigan, and they'll move here. They'll train under me, and we need more space here. You've been in my office. We don't have enough exam rooms. And the reason, Priya, I don't know if you understand the reason a lot of people can come from all over is the longest my treatment plans are. The longest is 5 days, so they don't have to be here long. Most people are 3 to 5 days, and they're done.
Wow.
That's why they can come in from everywhere because it's not protracted.
It's not forever. Oh, wow. And my question for you, I guess, is I've been a little bit trained in like craniosacral and with the Unclenched courses, they always talk about 5 grams of pressure. It's very, very light. Is yours similar to that? Is it more? Is it less? Is it totally different? Like
not at all.
Okay.
Not at all. Yeah. I have had years ago, Dr. Upledger's passed, and he would send me a lot of patients that he was struggling with.
Okay.
So yeah, this is not at all like craniosacral. It's not 5 pounds of pressure.
Yeah. Okay.
No, but yeah, I mean, you do the cranial bones. It's like priming a pump. Once you get it, but you got to remind and the bones can't move a lot, so you got to kind of coax them all to move. And it's like putting a puzzle together because all the other cranial bones articulate with a sphenoid. So you got to kind of coax things, and it takes a while before they start moving properly. It's not like putting the paddles on a heart during a heart attack. You do that and the heart starts beating. I wish it was that easy, but it's just a little different. And I mean, you stimulate the pituitary because it's in the way. It sits right in the cella turcica, so you can't help it. I mean, I have several women. I warn them. I say, listen, you probably can kick on your pituitary and hypothalamus. I'm going to change the time you have your menstrual cycle. Some skip one, some have an extra one. A lot of them get pregnant that weren't planning on it. I just had a lady, her youngest is 18, and I said, listen, you got to be careful. And sure enough, she came in. She was all red in the face. She goes, I am pregnant. I said, I warned you. And so now she has a baby.
Do you teach this to dentists?
I've been consulting a lot with different doctors, Dr. Mohammed Haddadzadeh, who's the researcher. And when I do talk to the neurosurgeon that I've spoken with, who actually brought me on, the NHL alumni, is Dr. Amin Kassam. He's the surgeon who's pioneered the surgery where he removes brain tumors through your nose so they don't have to split your head open. And he said, we want a doctor. We want either a dentist, a chiropractor, an osteopath, a medical doctor, or a physical therapist. He likes dentists, physical therapists, and osteopaths because he said they're a broader based training. Dentists are already well versed in head and neck anatomy, and they're used to using their hands. He said chiropractors and medical doctors get real stuck in their specialty and kind of hard headed and less flexible. He said
I don't think dentists are flexible at all, but okay.
Yeah, they're not.
He really likes osteopaths and physical therapists because their training is so broad based.
Yeah.
And
well, with that being said, though, because once you do this, I would love to learn it.
I want to learn.
It would
Will
take
my license let me do it?
It would take your whole practice. It would be all you do because the demand there's such a huge demand. And there's really, like Dr. Dr. Haddadzadeh, he told me, he said, once everybody figures out that this is out there, this is for concussions, he said, it's all anybody will do for concussions. Because all the traditional stuff like vestibular therapy and vision therapy and physical therapy and rest and this and that and the other, they're good modalities once this is done. then that will help the person heal quicker. And we actually developed a rehab routine with Wheeling University's PT school that brings our patients around quicker. It actually stimulates the diaphragm to push the CSF to help heal things quicker. And it's very measured so somebody can't overdo it. So once I'm done with them, then they get this rehab routine. And most of my patients, they'll resolve. There's such a thing as damage. Some cases you have to manage. I have a girl from North Carolina. She was 15. She was running cross country and a tree branch hit her in the head. Pituitary failure. She lost weight, severe headaches, 60-second memory. For 4 years, she thought she was 15. Couldn't remember anything past 60 seconds. And she was on Dr. Oz being interviewed because she couldn't remember anything. And one of my patients from here, whose daughter had the same thing, saw her. He's a pastor up here, and his wife called this lady. Anyway, she came here, and she's 22. She's everything. She's totally fine. They actually did a documentary on her called Caitlin Can Remember, on how she came here, and she's doing well. The point is, though, I still see her once a quarter because she sustained a lot of damage. So, some people you have to manage their case still. I have a fellow.
When you see her once a quarter, do you have to do the same 5-day intensive?
Usually it's 2 or 3.
Usually it's less.
It's less, yeah. Yeah, she got her degree, her driver's license. I mean, her mother said it was hard because she went from 15 to 21 in like 10 months. And she now had a young lady as a daughter. She was used to dealing with a 15-year-old. She wanted to date.
Sure.
Yeah. She's now, I think, a nurse. She got her degree. Yeah. Well, another case from Florida. We had a fellow getting his hours flying, and he was in Daytona Beach, and he took off in his plane, and 400 feet in the air, the engine quit, and the plane went down. Lost his right leg from the knee down. His head was split open to the brain. I have a picture of the head. The ER doctor took a picture in case he lived.
Wow.
Anyway, when he was in a drug-induced coma for 9 months.
Wow.
He came out of it, and they flew him here. He's now running a multi-million-dollar corporation, oil company. So, but him, I only see twice a year. You would think he would need to be here all the time.
Yeah, sure. Sure.
How can people find you? Are you on social media? Is it just a website? I want to put this out.
We're all over social media. If you just type in Charles Simkovich,
that's not easy to spell. Why don't we spell that for our viewers?
Simkov as in Victor, ICH.
Oh, that is easy. It's exactly how it sounds.
I got to finish the story about this kid that's flying the plane.
Go ahead.
My favorite part of the story. Before all this happened, he kept going into a restaurant in Daytona Beach because he had a crush on one of the hostesses for months. He couldn't muster enough nerve to ask her out. So he went in one day, and she taken another job. She's gone. So he thought, wow, I blew that. So a couple months later, he moved into a new apartment. Guess who his next door neighbor was? So he told this girl, he said, I was going to ask you out. I never had enough nerve. And so they started dating, and they were dating for 3 months when the plane went down. And when he woke up, the nurses told him she came every day and sat by his bed. Guess who's married now? I said, they should make the Hallmark movie out of that. It's a fantastic story.
Yeah.
It's so sweet.
Yeah. I mean, if there many bad things, that's a nice thing.
Yeah. So Charlie, let me ask you a question. So I give people an SPG block. So I take a Q-tip with lidocaine, go through the nose. I do it a lot because people tell me it clears everything up. It relieves the pressure. That they feel more, if they have a headache, it goes away. Do you do anything like that, or is it all bone manipulation that does it for you?
It's all manual. It's all manual. Yeah.
Mm-hmm. Mm-hmm.
Yeah.
So when can I come learn with you? I'm going to get on a flight tonight.
I don't know.
Yeah. Well, you guys better, you and Stacy need to work on that, because I think that a lot of people, especially, people that practice like Priya and I, and ICMO people.
Oh, I'll be
Well,
interested.
she's going to be speaking at ICMO this year. Priya,
You
you'll
are?
meet
Priya?
Charlie and her.
Okay.
Well, Priya is actually too, and so are you.
Yeah,
Yeah.
we're both speaking, I guess.
Yeah.
We
Yeah.
here's the thing. It's going to take we think a 6-month residency. But I've had a lot of people say, well, I want this to be an add-on. It will take over and become all you do.
Yeah.
And you'll crave the results because the changes are exciting. I mean, you take people can't read, they can read. People are suicidal. Like, your patient was suicidal. Look how that affected you. I mean, it's exciting and it's fun.
Mm-hmm.
But the demand is there. I was telling Dr. George, I mean, we're booked into September, October. We have a waiting list, so it'll just take over what you do. Because I can only do so many people. I can only take 15 new ones a week.
I want to learn as much as I can. So I'm going to keep an eye out for when you're offering classes.
A lot of our classes, or, when we get fellowships and things like that, they're like snippets, like, 3 weekends and then another 3. So we can still work our practices, but then we're learning on the side. Have you thought about anything like that, like to do every weekend for a year or something like that?
Yeah,
so that
we've tried that in the past, and it just was there's just too much information, and the flow doesn't continue.
Yeah,
and you got to relearn anatomy and physiology, and then the application, and then all the things and how it applies. Then you got to go over case by case what to look for. Like, for instance, if somebody has a very prominent palatine raphe, they're going to be harder because structurally they're a little bit tougher. You can't get to the pterygoid processes. If their maxilla is very narrow, you got a lot of work to do. You're going to have to spend, that patient's going to take you longer, because just like you put an expander in orthodontist, you have to expand that so the pterygoid processes have room to move. But like I said, the people with palatine raphe, they're a nightmare, but you can help them, but they're in your office longer. So, you got to learn all the different ins and outs. And that's why we want people to work with us here, so I can be there for them and say, here's what you're going to expect with this patient. I can even do the exam and say, here's the treatment plan, and make sure everything is done correctly. Yeah.
Well, let's talk about palate expanders. So I do some expansion on kids and adults. So does that make your job a little bit easier when they're
a lot easier? A lot easier. I love that. I see a lot of patients who had braces and they didn't put an expander, and I wish they had.
We have a local orthodontist who just pulled 4 bicuspids.
Oh, let's hang him up to dry.
I'm not going to say his name, but I don't want to get in trouble. I'm scared. But we're like livid. Like, my husband's livid. I'm livid. I'm like, what are you doing?
Yeah. That's a big mistake. Hey, years when I was young, they used to pull teeth, and you that makes everything smaller, which is a problem.
Right.
Yeah, he just did it. I mean, I'm talking like 2 days ago. He pulled 4 bicuspids.
Is it like an older dentist, like somebody trained a long time? Oh, my word.
I know. My husband texted me this morning livid, and he goes, "This is a travesty." And I was just like, are you going to say something? So we're talking about it, but it's like, what are you doing, buddy? Like, get with the times.
Right.
This isn't rocket science.
My one sister went through therapy with me, and then did ortho on her, and myself and my 2 sisters both had bicuspid extraction because we're old, and that's what they did then.
I've had it too.
Yeah. So my sister, though, we put her in ortho and put 4 implants in where the bicuspids were. So she has the prettiest, broadest smile because we took her back to where she should have been.
Sure.
But unfortunately for me, I'm still a little on the constricted side. But
remember, you talk about things, but remember when I was with you in Louisville, and the one doctor was talking about a fusion of, I forget it was the pterygoid processes to somebody. One doctor was doing that procedure, and I said that's a huge mistake. I mean, they're going to restrict the movement of the sphenoid. You remember what I was talking about? I think he was from Chicago, but anyway, I was shocked that somebody thought that was a great idea. I don't know what the purpose would be.
Right. I vaguely remember that.
Yeah.
But anytime you want to restrict something and not let things grow, and then you're talking too about the muscles of the tongue and the palate and how your swallow should be, and I mean the sphenoid bone is the roof of the mouth, right?
No, the pterygoid processes are there. The greater wings are here.
Mm-hmm. Right.
And then the brain sits right on, and your eye muscles attached to it. I mean, it literally is Grand Central Station.
It's Grand Central Station, yeah.
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 And
everything moves off it. So when you move the sphenoid, I got to check the temporals, and you got to check the occipitals and the parietals. Sometimes I have to, the zygomatic bones have moved posterior. Yeah. So you're behind. That's not fun. That hurts. But you got to move the zygomatic bones. And talk about tough cases. For example, if I have a patient comes in, they said they have searing pain here or here, the zygomatics, or at the angle of the jaw, there's probably a cardiac issue. I had one guy, he was just saying, I went to a dentist, they gave me a bite plate, it's a TNJ problem, I'm having intense pain right here and right here. I sent him to a cardiologist, he had triple bypass. Because that's a hallmark sign for
jaw can be the
angle of the jaw or here. Yeah,
sure.
That
things these doctors have to know. So, like my aneurysm patient, you got to recognize that stuff. Yeah.
Right, and I think that's even good for us as dentists to recognize.
To think about,
because when people say they have pain here, our brains go to the masseter origin insertion. It's probably something with the masseter, and a lot of times we're just tunnel visioned right down to what we know and not thinking of the bigger picture. Now, if they're talking, numbness down their arm and in their jaw, that's a little bit more. But if it's just slight and discreet, you're right. Like you better open up your eyes.
This guy was funny. He was talking about intense pain here and here. And that's so, and they'll describe it as it's just so intense they can't stand it. And when I referred him to a cardiologist, he said, "Oh, you're just a terrible doctor. You can't fix it." And I said, "No, I want you to go see the cardiologist." So then, we went and looked. What's the test they do when they look to see the blockages on an arthrogram? But anyway, you can see the vessels of the blood.
Yeah.
Yeah. Anyway,
do a cath.
I forget what it's called. A heart cath. So
yeah.
So the cardiologist, the wife said, "Can you please come to the hospital because my husband is out of control. Maybe he'll listen to you." He's screaming at the cardiologist. So I went to see him, and the cardiologist said, he has 9 blockages. He needs a triple bypass. So he showed me the heart cath. Well, there was 12. I said, "There's 12. This patient had the cardiologist so worked up, he was upset. He was saying that, and he said, "Oh, I missed those 3." And the patient's like, "Oh no, you're a damn cardiologist." I said, "Well, here they are." He said, "You don't know how to read a heart cath." I said, "Here's your blockages." Hey, we had triple bypass.
Wow.
This guy is funny. He actually called me the night before his surgery. He goes, "I want to know what you're going to do if I die." I said, "I'll bury you."
Yeah, there you go.
That's something else. But he's fine. This is in the game now.
So, Dr. Charlie, we get a lot of questions, and if people know that I always refer my concussion people to you. So, but I always get a question, is it ever too late to go see him? Like, I had a concussion 20 years ago, and then I had another concussion 2 years ago. I was in a car wreck and had whiplash, but no concussion or whatever. When is it too late? Like, okay, I cannot help you because it's been X amount of years, or is it never too late?
Well, it's almost never too late, but that's one of the factors. And remember, I said determining how to treat, how many days to treat, what I need
Sure.
to do. That's a factor. I mean, it's hard. It's more work for an older injury because you have a lot more damage to undo than
Good.
a fresh injury. Fresh injury always responds quicker. So yeah, as an example, I had a fellow from Philadelphia. He was in the Army in a tank 30 years before he came into me, and the hatch fell and hit him in the head, which is 300 pounds. Well, he actually went blind for 2 days, lost his vision for 2 days, was knocked unconscious for like 10 hours. And for 10 years, he degraded. Well, I understand why, because the lymphatic system was failing. His brain was dying, basically. Yeah. Anyway, he came into me 30 years later. Now, did he take longer? Yes. It took me 1.5 years to resolve him. But he said the only thing that helped him. So he came back about every 8 to 10 weeks, and I would do another set of treatments for him. He took a total of maybe 6 or 7 intensive treatments, but it's been 8 years. I haven't had to see him. He's doing great. He's an engineer and thriving. And in fact, I think he's a testimonial on my website, Scott Edgell. He wrote it. There's a picture, him and I together. But yeah, his injury was 30 years before he came in. And the little from North Carolina, she was 4 years before she found me.
Yeah.
Oh, wow. That's amazing.
Yeah.
That's good to know. And I think that this is something that cannot go unheard, and people need to realize the seriousness of concussions and how they can possibly build on each other or, cause your vision, like you were saying about the sphenoid bone with the ophthalmic artery and the nerve. And people always say, my eyesight is worse, but sometimes after they've seen you, their eyesight gets better. Not that it might not go 100%, but their glasses and their prescriptions change, and it's a lesser.
Change the prescription of glasses. That happens often. I have a lot of Amish patients, and a lot of them has false teeth, and they have to get their false teeth refitted after I treat them because I changed the way their palate is shaped. And
well, that's a good question too. So if they're wearing dentures and you adjust them, then does the denture, once it's inserted, make it compress again?
Or it just doesn't fit.
So matter of fact, there's such a thing as Amish dentists, which I thought I knew everything about the Amish, but I didn't realize it. Basically, they just pull teeth and get people dentures. Yeah. And there was a lady in here this week from upstate New York who said, "Oh, my husband's an Amish dentist, and he has redone probably 200 of your patients' dentures because they didn't fit anymore. So he had to refit them because everything was different."
Wow.
That's very common. And a lot of people get their eyes checked again because of their prescription changes. I've had a few people were able to throw their glasses away, which is amazing. So the eye muscles affect eye tracking. So if you have a child that can't read, their tracking is off. So they're going to reread the same line over and over, skip words or reread or lose their place easily. Or if they're playing baseball, they can't follow the ball and hit the ball anymore. Then the cranial nerves 3, 4, and 6 I talked about, they're very responsible for saccades. The saccades, you're familiar with saccades? Saccades are vision, like if you're looking at a horizon at a horse running across a horizon, your eyes actually skip. It skips like a synapse on a peripheral nerve, but your brain puts it together as smooth. That's a saccade. So when those 3 cranial nerves are stretched because the sphenoid might be torqued, that the saccades don't work anymore, and they just say, I can't drive anymore, I can't see, things are jumping on me. So the saccade, SACCADE, is not working. So when we stabilize and make the integrity of those 3 cranial nerves proper, then that helps that. So that's what I'm saying. There's a whole lot goes into this from several different angles.
So then that brings me to, what about a traumatic birth in the canal? Like, would that squeeze the head or misshape the sphenoid? Or
Often.
And how young of a patient do you see?
Well, births can be traumatic. The Amish community north of here in New Wilmington, almost all the women, when they have babies, bring their babies in for a well baby check just to make sure they're okay.
Wow.
So the baby has to come through the birth canal. There's molding of the cranial bones over top of each other. When it comes through the canal, they pop into place. Hopefully that goes well. Usually it does. That also stimulates the pituitary to kick on, which is why a C-section birth doesn't do that. And then you have a planned C-section versus a emergency C-section. Emergency C-section, they get the baby out real quick. So there's a rapid decompression. So there's almost like an inside out, an internal cranial injury, because the CSF rushes to the cranial bone, cranial fault, and you have trauma there. As far as age, I'll give you an example. My wife walked into the office one day and there was an Amish lady holding a baby. And she said, "Oh, when was the baby born?" And the Amish lady said, 3 hours ago. And what happened was it was born at Jameson Hospital up the road. The baby's head was banana shaped. It was a traumatic birth. And the OB-GYN said to this Amish lady, "Get that baby down there right away." She left the hospital and came down here.
What?
Yeah.
Wow.
Yeah. 3 hours.
Kudos to that mom.
All these Amish women, they put those babies on a table and, babies cry, and they're like, "Do whatever you got to do." Yeah, they're tough.
Right.
They're tough.
Yeah.
Woo, I am not.
Is there no more banana head baby?
Yeah, he or she, I don't remember if it was a boy or girl, it took one day. Yeah.
Sure.
I wish I had brought my baby to you. She had a rough go of it, but
Wow.
Oh, I see tons of birth trauma. The good thing about them is, like I said, babies, we don't have to do an extended any kind of treatment. They usually respond immediately.
Okay, so then that makes me think, how these babies now wear those like kind of helmets to shake their skull?
Sometimes it's necessary. In severe cases, that's still necessary. I had Amish baby had craniosynostosis where the sutures were fused and the head was growing this way and straight backward. This was all fused. So this parents brought this baby in. I said, "Go to Children's Hospital. She's got craniosynostosis. She's going to need surgery." So they went down there. Well, they didn't want to take the neurosurgeon's word for it. They said, "We're going to check," because they agreed with me. They brought the baby back here, and I said, "Everything that doctor said this baby needs is going to die if you don't get the surgery." So, that took care of that. But they trust. I mean, Amish people think I can cure hangnails, So, but it's a compliment,
Sure, it sure is.
Yeah, but that surgery was necessary,
Yeah.
So.
Yeah. Wow.
Sometimes it is. All right, Charlie. Thank you so much, Priya.
Thank you for having me on. I appreciate it.
Yes, thank you.